Thousands of people fall each year, resulting in harm, distress, and in some cases, death. A significant number of falls occur in rest homes and hospitals, but most happen in the community and around the home. Many of these falls are preventable.
2 to 3 years ago, it became apparent at clinical board level at Canterbury District Health Board that we had a significant problem to do with falls in hospitals, especially for the elderly. At the same time, we also became aware of the significance of falls in the community, both the number and the severity, and how a number of frail elderly people were ending up in our care. Around 40 people a week were attending our emergency department, people 75 years and over who had had a fall in the community, and were admitting between 60 and 70% of those people into hospital care. So clearly we had a problem that we needed to solve. We have a responsibility to our local community and to our clinical staff to make sure that our patients are safe in our care, and if we have a preventative strategy that we know is evidence-based and is effective, we should be putting that in place in the community to prevent falls if we can. So we've invested $1 million over a 2-year period on a community falls prevention strategy, run in primary care by a primary care network, if you like, where clinicians communicate well with each other around the common problem, and we deliver services closer to people's homes. So as part of that overarching strategy, we've introduced a home-based falls prevention strategy that is significantly reducing our demand upon emergency department and demand on our hospitals.
Yes, the last place I want to end up is in hospital. And also, I don't want to go into a home. I want to stay in my own house and be mobile if I can.
When he first came out of hospital, after they said he was all right, he was having about 15 to 20 falls a week. He would just walk and fall over for no reason.
The mortality rate from people falling over and fracturing their hip is actually really quite high.
The evidence is clear that if strength and balance exercises are introduced to those people who have difficulty with standing balance and leg strength, then you have the potential to reduce their falls risk by almost 40%, and their risk of hospitalisation by a similar amount.
DHB's role is really to manage the health of our population, and we've got a set budget within which we need to do that. And because those resources are finite, we have to find ways in which we can intervene earlier to keep people well so that we don't end up getting those downstream effects.
But it was happening that much that it was getting me down. I was following him around the house in case he fell. If I had to go on like this all the time, I couldn't.
The falls prevention area is an area that we think there's strong evidence for investment upstream and early on to keep people well in their community so that they're not going to have those falls that we end up paying for somewhere else in the system.
We've adopted a modified version of the Otago exercise program in Canterbury.
And then try and stand up without using your hands.
A key element is to deliver this preventative strategy, this exercise program, if you like, in people's homes.
I would never ever have thought of them myself, but having someone tell you about it and show you, it makes all the difference.
Holding onto the bench with both your hands and bringing your leg up. Very good. Keeping your body up nice and tall. That's the one. Very good.
Can't go much taller.
So now we have a well-integrated system around falls prevention. We have the pharmacist, the practice nurse, the general practitioner, the local physio, and the local falls champion, who is usually a physiotherapist, but in some cases is a qualified nurse as well, who work together around the overall care of that person in their own home.
Standing up. Well done, Liz. Pretty easy, hey?
So my role is looking at the patient and how they're managing to stay in their own home and giving them a set of exercises and a walking plan so that they can build up their strength and balance and maintain their level of independence through continuing to strengthen. And once we've established where their issues with strength and balance are, then we develop a kind of a well-rounded strength and balance program that they can do easily every day within their home environment.
He's not falling so much, so he gets up out of that chair and I don't follow him around. I can go out for a couple of hours a day and I don't worry as much as I used to.
And the real benefit of that is that they They can do it if it could be snowing outside and they can still do their exercises, and they can do it when it suits them, so it's not going out to join a group once a week. They can do these exercises a little bit each day to improve their overall exercise threshold.
When you sit down, you can put your hands down though, because it tells your brain where your bottom should be going.
Not only are we delivering strength and balance exercises in people's homes, we are incorporating a home hazard check provided by the same person.
We really need to look at their whole package, the patient in their home environment and how the risk factors are involved. Bathrooms, mats, cords, rugs.
See how easy it would be to catch your foot underneath that? Especially, if you're getting up in the night to rushing to get to the toilet,
Right.
The last thing you want is to be tripping over your mat in the hallway here.
They came out and asked me about a handrail, and I said, well, I've never ever thought about it. And it wasn't until it got put in that I realised just how much I needed it. I don't know how I got up and down the steps without it.
Another thing that's really good is that you've got the torch beside your bed, so if anything happens during the night, you can grab that quickly. And it's great that you've got your phone there, so if there's any emergencies or if anyone rings, you're not having to rush out to try and get out of bed in a hurry to find the phone.
So although falls prevention becomes the focus, the safety net really, if you like, is wider than that. Part of the strategy is to facilitate fantastic communication amongst that team and to highlight other issues that come up as part of that in-home care.
So this one's the nosy neighbour one. Lears up onto your tiptoes.
And often when we go to see a patient in their home, we'll find a whole raft of issues that their GP may not know about because they've never seen the home environment.
In the past, people used to come into the pharmacy and tell us stuff that they hadn't told their GP, and it's really great to be able to have those linkages, those communication linkages with the GP or the practice nurse or maybe the physiotherapist. It's sort of more eyes around the patient.
We see a patient, we're 15 minutes with that patient, and yet we can now bring in these wonderful services like medication management, like falls prevention, which is involving, pharmacy, OT, physio, all that allied health input.
And so often we pick up things, perhaps they aren't taking their medications properly but don't want to tell their GP, or the GP doesn't know that, or there's a whole heap of home hazards that no one's identified because they've never had anyone come into their home, or that their cupboards are bare and they're really not eating because they've got transport issues.
Most patients would prefer to be looked after in their own home, and we talk about the preferred place of care. The kind of mantra is best care, right place, right time, that sort of thing. So we're looking at what is best for a patient.
Patients love having someone that comes back, and they often say it's really nice to know that somebody cares and you'll keep coming back to see me and you care about how I'm doing and you care about keeping me independent.
And away we go.
Very good.
And then when we do the 6 and 12 months reviews, patients, we get them to do the sit to stand test and the balancing tests, and I didn't realise how much better I'd got. I didn't realise how much confidence I'd lost until I started to get it back again.
I would say if he hadn't have done those exercises, he mightn't have been able to stay home. He's improved so much, and he's kept them up. He's been doing them twice a day now for months.
Very good. You just do good, Dot.
I can do it all. I really do think that this is helping me to stay where I am, in my own home. Yeah.
I think this is absolutely working. I've seen it myself with patients who've had perhaps a fall, and I've referred them off to the falls prevention team. They've gone and they've done a wonderful assessment, really checked the house out. They've done strength and balance testing. They've got the patient motivated. The pharmacy people have come in, checked their medication, made sure that that's all good. Sometimes even prompted me on putting the patient onto vitamin D because I may have not had that particular patient on vitamin D.
And apart from being the sunshine vitamin, it helps with your bones.
They all report back to us. It's a great collaboration, really, and just makes our job in general practice a lot easier and obviously much better for the patient.
Because of this new kind of integrated approach and the way that we're liaising a lot more with primary care and GPs and community groups, we're seeing patients at a much lower threshold, so they haven't necessarily had a really significant injurious fall yet. We're able to see a whole heap of more able patients, keep them independent at home before they really become frail and at serious significant risk.
I am really glad I took on this program. I wouldn't be as far ahead as what I am today without it.
In the last 12 months since we've started this initiative, we've had a 7% reduction in the number of people admitted to hospital having had a fall in the community.
And so for the first time, we're seeing a decrease in falls in ED and a decrease in admissions with fall as a cause for the first time over the last 6 months. And that's a pretty exciting place to be in.
I would be tempted to say we're delivering it at half the cost with twice the benefit because we're targeting the right people.
I think he would have had to go into a home to be looked after. I think if we hadn't have had that help, I don't think he would have been able to stay home.
I am feeling great at home.
We're not used to working in this way, but you can so see the benefit of it, that it feels quite comfortable, so I think it's going to be great.
What makes me want to get out of bed and go to work in the morning is seeing the results for individual patients
I find that it gives me a lot of professional satisfaction.
and seeing how much their independence and their strength and their balance improves.
The people who I've been connected with have made such a difference to my life.
You've got to come up with a new way of doing things and preventative strategies. If you're going to take healthcare management or healthcare architecture seriously, preventative strategies are the way to go.
In all areas of general practice, this collaborative approach has got to be good for us as GPs, good for the patient.
In the next 10 years, the population of people over 65 in Canterbury will double. We cannot keep delivering healthcare in the same format. We need to deliver it in a way that reduces the demand on services in the future and keeps people well at home and helps them to take responsibility for their own care.
There's lots of things that I can't do, but there's not a lot. I can't mow my lawns, but I would love to have a go.